So cardiovascular disease and cancer are intrinsically linked for a number of reasons. I think first and foremost, many of the pathophysiological processes that drive the pathophysiology of cancer also drive the pathophysiology of coronary artery disease. Many of the risk factors that we think about in terms of cardiovascular disease are also the same risk factors for cancer, so diabetes, smoking, hypertension, obesity. And many of the strategies that we use to manage patients with cancer can precipitate acute cardiovascular events. Many of the drugs that we use, such as immune checkpoint inhibitors, are very strong risk factors for coronary artery disease. These are some of the drugs that we use around treatment of cancer, and you can see that many of these drugs can cause vasospasm. Many of them can increase the risk of myocardial infarction. So it's not unusual when managing these patients. Often when you diagnose a patient with cancer, you start treatment. That's when the patient will then manifest their first cardiovascular event, and often that cardiovascular event is an acute coronary syndrome. Now, we often think of patients with cancer as being relatively rare in our practice, but it isn't. This is some data that we published looking at 15 years data from the United States. And the important thing to say is that overall cardiovascular disease in the general population admissions have reduced by about 10%, whereas in the cancer populations, cardiovascular admissions have increased by 25%. So seeing a patient with an acute cardiovascular presentation is common in patients with cancer. And generally, these presentations happen at around the time of diagnosis. And as we've discussed, many of the treatments that we give for patients with cancer can precipitate acute cardiovascular events. So you can see that the highest odds of acute cardiovascular events are usually in the first 12 months of cancer diagnosis. We know that coronary artery disease is one of the most prevalent and highest incident conditions in patients with cancer, with, if you're looking at mortality statistics, around 40 to 60% of patients with cancer that will die from a cardiovascular event will die from ischemic heart disease. And it doesn't matter whether we've seen improvements in primary and secondary prevention in cardiovascular disease. Nevertheless, coronary heart disease is the number one cardiovascular killer of patients with cancer. Now, you may think, well, okay, that's fine, but why is PCI in cancer important? And the reason why it's important is that patients with cancer account for about 1 in 10 of all acute myocardial infarction presentations, whether it be patients with a current or a prior history of cancer. This is an increasing problem, as I've shown. And one of the problems is that these patients tend to be managed medically. They don't get revascularization, and subsequently their clinical outcomes are rather poor. So you can see that patients with current cancer, their mortality rate is almost double that of patients without cancer. And there are many reasons that these patients don't get invasively managed. And that's often because we have traditionally thought of there not being much of an evidence base in patients undergoing PCI with cancer. Many of these patients are excluded from randomized controlled trials, either directly because of cancer being an exclusion criteria, or indirectly through virtue of the fact that these patients have poorer life expectancies and increased risk of bleeding complications. We often think of cancer as a homogeneous condition. This is some old data from the Mayo Clinic looking at 5-year follow-up data of patients undergoing cancer from PCI. And the first thing that you can see is that patients with cancer have an increased risk of future MI, future risk of stent thrombosis, and future risk of bleeding events, which makes these patients challenging to treat. And one of the reasons is that many of these patients have many different bleeding diatheses that would contribute to their increased risk of bleeding complications. So active cancer by itself is one of the criteria for HBR in patients undergoing PCI. But also, many of these patients have liver metastases, they may have anemia, low platelet count, particularly in the acute phase of chemotherapy. They'll have bleeding diatheses, and they often have planned surgery, whether elective or unplanned, with the diagnosis of cancer shortly made after initiation of antiplatelet therapy. Again, PCI in patients with cancer is not rare. I mean, we don't have much in the way of randomized controlled trial data, but we do have data from administrative work, much of which my group has published, and around 1 in 10 of these patients undergoing PCI has either a current or a prior history of cancer. Now, the important thing is that many of us think of cancer as a homogeneous condition, and of course it isn't. Lung cancer is very different from breast cancer. Prostate cancer is completely different from colon cancer. And so when thinking about the prognosis or the longer-term outcomes of PCI in patients with cancer, you have to think about the cancer type. And the really important thing to say is that patients, say, with breast cancer or current colon cancer or prostate cancer don't have an increased risk in short-term mortality or even longer-term mortality following PCI, whereas patients with lung cancer do. Once they get metastases, though, then clearly these patients are a more advanced stage of cancer and they have much worse outcomes. When it comes to bleeding complications, however, patients with cancer are a high bleeding risk cohort, but again, it varies by cancer type. And so when you look at things like colon cancer particularly, this is the cancer with the highest risk of bleeding complications. And so when thinking about antithrombotic strategies, think about cancer type, colon cancer particularly, very high risk of bleeding events, whether it be with or without metastases. And in terms of the balance between ischemic and bleeding events, that again very much depends by cancer types. So things like colon cancer very much portends to worse outcomes with relation to bleeding events, whereas something like prostate cancer or breast cancer, probably more, or lung cancer, probably more towards ischemic events. So really, when you're thinking about PCI and cancer, you need to think about the type of cancer because the balance between bleeding and ischemic events is very different. Generally speaking, hematological malignancies, particularly ALL or Hodgkin's lymphoma, very high risk of bleeding complications. Colon cancer, again, very high risk of bleeding complications. Whereas some of the more solid tumours, such as lung cancer, much higher risk of ischemic events, where their absolute rate of bleeding events is relatively low. And so when you think about cancer, think about the cancer type, but also think about risk modifiers. So risk modifiers include things like, has the patient had radiotherapy? That leads to much more calcific disease, much more challenging to treat, particularly osteal disease, so some of the lymphomas that get radiotherapy. Think about whether the patient has anemia or thrombocytopenia. We know that both anemia and thrombocytopenia increase the risk of bleeding as well as ischemic complications. We know that metastases, as I've shown you, portends to worse outcomes. And certainly something like breast cancer in the absence of metastases have very low risk. And actually the risk, once you adjust for differences in risk factors, is very similar to the non-cancer population, whereas lung cancer patients have a higher risk. And part of that risk is because of the non-cardiovascular competing risk of mortality related to cancer. So when you're thinking about PCI in cancer patients, think about what are the factors that may increase the risk, so radiation, think about anemia, thrombocytopenia, and clearly your decision-making around antiplatelet agents will vary depending on your thrombocytopenia and anemia counts are. Generally, I don't use newer antiplatelet agents, particularly for those cancers with higher bleeding risk. I generally use aspirin and clopidogrel. Intra-procedure, always go radially. I would always advocate intracoronary imaging. This is a very high thrombotic risk patient, and always drug-eluting stent over bare metal stent. Generally, for DAPT duration, I would say that I generally go towards the shorter duration. We have many randomized controlled trials, including MasterDAPT, that shows superiority of 1 month DAPT in these high bleeding risk patients compared to longer periods. So unless it's something like lung cancer, generally for most cancer types, I go short, even in ACS situations. And again, this is just guidelines showing that you have to balance ischemic and bleeding risk, and certainly in the cancer patients, I go towards shorter DAPT durations. So I think in conclusion, so my time is up, patients with current or historical cancer are increasingly common. I think it's important to say that patients with cancer, unless they have a prognosis of less than 6 months, should be managed invasively. They're at increased risk of bleeding and ischemic events, and so you have to think about the type of cancer and the stage of cancer. I very much drive towards shorter antiplatelet duration in these patients, because for most cancers, bleeding events far outweigh the risk of ischemic events. And I think really, in the cold light of day, you need to consider your approach, perhaps speaking with cardio-oncologists. In the STEMI situation, though, whether a patient has cancer or not is irrelevant. You should go ahead and do the PCI, except in patients that's terminal with a life expectancy of 6 months or less. Thank you.